to give us an update on BESC and how the hospitals in Broward are catching up with the comprehensive submissions.
All right, so let me load up my slides. But from the latest update through Jeffrey Walker and ASA, all the Broward stroke centers are now participating in Get With The Guidelines, submitting the data. And I think Maria, I don't know if she's on the phone, but when I spoke with her at ISC, they said that the pending hospitals, the HCA hospitals, they had not finished submitting the paperwork for the Florida Puerto Rico Stroke Registry. So that was as of a week ago, unless she has an update to that. And we'll follow up with her with regards to what the status is for generating the hospital level dashboards for the April sort of data generation. So what I'm referring to is the first quarter is January to March. So at the end of this month, essentially all the hospitals that have been submitting data to Get With The Guidelines over the past 3 months and concurrently have been in Florida Puerto Rico registry, the UM group will be able to generate hospital level dashboards. So just merely participating and Get With The Guidelines is not enough. The hospitals, HCA, they have to go the extra step of getting into the Florida Puerto Rico Stroke Registry. Niels may have an update for Palm Beach. I'm not sure what the status is for Miami-Dade. You may also know about that.
Microphone, please.
We've heard that they want to become participant and Get With The Guidelines, but there was paperwork to be signed and legal to be done, and I don't think there is data going into the registry yet from those hospitals.
Okay. All right, perfect. So, perhaps Maria, we'll touch base with her for, the first quarter of 2017, whether retroactively they can generate dashboards for some of these hospitals that are not yet participating in the registry. Again, keep in mind, 2017 is mainly for hospitals to understand in a blinded fashion whether, where they stand in terms of quality of the care, right? So none of the data for this year is going to go to EMS. It's mainly, incentivizing hospitals to understand how they are and then where they fare compared to the other hospitals. Okay? So do you guys have any questions about that? Okay.
Before we go ahead, I'd like to announce that unfortunately our online YouTube doesn't work, but I will be able to upload the high resolution just like I did last time. So anyone who tries to check or find today's lecture right now on YouTube, it's not going to work because the Wi-Fi refused to cooperate. I have Wi-Fi signal. I can't upload. I think there is some problem with YouTube upload. So anyways, but retrospectively, all the lectures will be in high resolution on YouTube. Approximately, I need a week for that.
All right. So, I mean, we appreciate all your efforts and, definitely understand the technical difficulties. But, at least it's being captured on video and it'll be available online later. So this is just for you guys as reference. I added Aventura Hospital, technically part of Miami-Dade, and Westside, part of Broward, to the list of CSCs that are going to be participating in Florida Puerto Rico Registry. And so this is, sort of where we stand right now in terms of generating the first round of dashboards. So I just wanted to go over kind of what data the group is initially going to focus on in terms of, from all the range of variables that are submitted to get with the guidelines to better understand the quality of care. So stroke volumes, ischemic hemorrhagic, so that'll be available to them. The number of IV TPA treated cases for the quarter, and then the number of mechanical thrombectomy cases. And within those, the metrics for TPA, door to needle time, they'll be able to generate, and then for door to puncture. Keep in mind that they have to submit the data in terms of these granular metrics, specifically groin puncture time, to get with the guidelines so that they can extrapolate from there. So for those interventionalists in the room or listening in, if you're not capturing some of these metrics, I strongly encourage you to do so, such that the data can be more valuable. And then for the thrombectomy cases, we want to look at the overall metrics based on the current guidelines. So patients treated with NIH 6 or higher and last known well within 6 hours. So that's based on the current ASA guidelines, and specifically the anterior circulation strokes. I believe that this gives us a sort of a good benchmark based on the guidelines where centers stand. Of course, knowing that there are centers such as ours and others, perhaps Tenet and Cleveland Clinic, that are treating all types of strokes, LVOs that are wake-up strokes, posterior circulation, basilar, PCA, et cetera. But currently, we don't have strong evidence for those subset of cases. So that's why, at least to level the playing field for what are the strokes that we all should absolutely be treating, are the NIH 6 and higher and last known well within 6 hours anterior circulation. Does that make sense? Okay. And so, the data that you all are submitting to get with the guidelines is going to include all the cases. And over time, as the guidelines evolve, the evidence is there. We can certainly extrapolate the others, such as the M2 occlusions. A paper just came out supporting treatment of M2, cases, as well as the basilars, the PCA, and so forth. And then, most importantly, the outcomes. Regardless of what the metrics are, for door to puncture, how are these patients doing in the long run? And we can certainly add more to the dashboard as we go on. If you have some sort of strong sentiments about what else we should be looking at, but I thought let's start with sort of this core of what we intend will give us a good benchmark for quality. Anybody else want to add anything immediately to this that I have not listed? You can feel free to speak up now, or we can chat afterwards. Again, we're going to wait until end of this month, and then the quarterly data, the dashboards will be generated. Okay, so just prior to ISC, the ASA came out with this mission Lifeline. So it was really exciting to see in terms of the pre-hospital protocol. It's now being sort of more cemented in terms of appropriately triaging large vessel occlusions to a comprehensive stroke center. So I know this is hard to read probably, but what I'll just highlight is, so for patients picked up in the field after EMS does their initial assessment in terms of stroke, potential stroke, stroke mimics, they're advised to perform one of the large vessel occlusion stroke scales. So either the LAMS, RACE, CSTAT, FAST-TD, et cetera, VAN+. And based on that, if there is a suspicion for large vessel occlusion, then the next question, is it symptom onset if it's available less than 6 hours? And again, this is based on the current guidelines. Then EMS is advised to triage those patients to a CSC. And what it says here is as long as it doesn't add more than 15 minutes of travel time, taking it to the patient to a CSC versus a PSC. And essentially, from there, they have advised going to CSCs or even PSCs if there's no nearby CSC, to PSCs that have endovascular capability. Okay, and some of you may have heard Joint Commission is thinking about a intermediate designation. So a PSC is currently all hospitals that can give IV TPA, and then PSC plus would indicate hospitals that can administer IV TPA as well as they have endovascular capability to perform mechanical thrombectomy, even if it's not the whole gamut, of 24-hour neurosurgical capability, aneurysm management, subarachnoid hemorrhages, so forth. If they can provide mechanical thrombectomy, perhaps in the future those centers will get a PSC plus designation by the Joint Commission.